Assalamu alaikum, Mr. Chairman, panel. Thank you very much. My presentation is about annular tear or rupture in TAVI. I have no disclosures. The first case is a 94-year-old gentleman who was actually quite fit, not diabetic or hypertensive. He had CKD with a GFR of 40, was doing well, but recently before presentation was having progressive shortness of breath, chest pain on exertion, and because of this and his age, he was having limited mobility. He's basically, he was referred from another cardiac center down south. His echo basically showed an EF of 40% with abnormality, regional motion abnormalities, and an LV that was slightly, distended, and the aortic valve was actually tricuspid, severely calcified with a mean gradient of 76 and a valve area of 0.6. His ECG was not remarkable. So this gentleman was sent over for a transcatheter valve. We did his cardiac CT. Basically, his area was 536, which basically falls in the range of 26 millimeters valve, the kind that we're using. You can see that he had pretty significant calcification in the arch and also in the aortic valve. I want you to notice the calcification extending into the LVAT on the left lower end. He also had annular calcification. That was something we had in mind. Now, his vascular axis, despite being calcified, was reasonable size, so that was not an issue. He also, when he came in, he had an angiogram already done that showed a borderline mid-LAD and significant proximal RCA stenosis. The LAD was FFR'd by us, and it was positive. So given his age and other, functional status and problems, basically the heart team thought that he's not a candidate for surgery, and we'll proceed with catheter intervention. The decision was to basically PCI the coronaries because we could see the regional wall motion abnormalities and also the chest pain that he was having, which could be attributed to the coronaries. So we decided to use a balloon expandable valve. 26 millimeter would give us only 3% overinflation. So this was okay with the amount of calcium that he had. We would use a right femoral axis in the usual protocol manner with closing with ProGlide. We tend to go most of the time with a radial pigtail axis, and we don't generally predilate. So his coronaries were stented during the same session with acceptable results, and then we proceeded with a transcatheter valve. So the valve was deployed, as you can see, after that, we did an angiogram. Looking at this, there was some AI as we had a paravalvular leak. So as we were discussing what to do next, the patient basically had severe chest pain, became very agitated on the table, and we kind of reviewed the angiogram again, and this was not noticed the first time. There's extravasation of the contrast, underneath the left main. So the patient being very agitated, he was intubated, echo showed pericardial effusion. The pressure started to drop, so we did a subxiphoid drainage immediately, 500 cc's of fresh blood drained, and we prepared for conversion into open heart surgery. The patient was transfused, reversed the heparin. We did not give products because of fear of, the stent. He drained about 800 cc's, remained stable with inotropic support. T did not show any tamponade, and he was stable enough to shift him to ICU. We kept him intubated for 48 hours electively, and he was extubated later post-op day 2. The drain stayed for a few days, and the final echo showed trivial paravalvular leak with a mean gradient of 6. Patient being older from the south stayed for about 10 days in the hospital. The second case is an 84-year-old lady who is diabetic hypertensive on dialysis. She's blind, she's only 40 kilos, and she's bedridden and not mobile, but when she was having dialysis, she was having syncopes, and sometimes seizures were reported. Echo showed an EF of 43% with basically a low gradient of 35, but a valve area of 0.7. Her ECG was not remarkable, and she had a small annulus, but reasonably good coronary height. The calcification was not a concern at this stage. Being a small lady, we thought the access would be difficult, but she had good access. Her Euroscore was not high, but she was a very frail lady, bedridden, and the only reason why we would do a TAVI on her would probably be to improve quality of life on dialysis. We would use a balloon expandable, 20 millimeters, a right femoral access. The TAVI was done. We checked the coronaries on CT, and they were reasonable, so we proceeded with TAVI without coronaries. And after this, the angiogram basically showed some AI. So we decided that, to post-balloon expand. I apologize that the image was not recorded, but the final result was very good, and there was no paravalvular leak. Patient was basically taken to CICU. Few minutes after arrival, she had severe chest pain. Echo showed pericardial effusion. We did a percutaneous drain, intubated, but it continues to bleed, and she became unstable. We rushed her to the operating room, and she was basically converted to an open cardiac case where we had to replace the aortic valve. And opening the aorta, there was a tear, a vertical tear between the left and right commissure that was repaired, and we put a 19 valve, which was sufficient for her size, and there was no room for root enlargement in this case. Patient was shifted to ICU in a very unstable condition on high inotropes and passed away after 6 days because of cardiogenic shock. So we have two cases of annular rupture that ended differently. This is not a very common complication, but it is something that it's devastating, and it happens less than 2% of the time. The major predictor is subannular calcification, and with the use of balloon expandable valve, the risk increases by 11-fold. Basically, annular calcification itself is not a predictor for rupture, but it's a predictor for post-balloon dilatation, which is a predictor of annular rupture. Small patients are high risk for annular rupture, as indicated in some studies, and women, even after correction of other factors, are at risk of annular rupture. Prosthesis choice is also a factor. Balloon expandable valves are associated with higher rates of annular rupture than self-expanding valve. Self-expanding valves and basically balloon expandable valves are high risk also in oversizing over 20%. And self-expanding valves rarely cause balloon rupture, annular rupture, but there are times when we pre or post-balloon dilate, and this could increase the risk as compared to the balloon expandable. How to prevent this? It's very, very important that you plan your case by cardiac CT pre-op, consider all variable calcification, and the size of the valve. Underfilling the balloon by 1 to 2 cc's when using balloon expandable valves for high-risk cases. In these cases, we did not reduce the volume because actually the size was only less than 3% or 4% over inflation. So we didn't think that it was going to be a risk. And using supraannular sizing, like the one we do with bicuspid valve, is recommended by certain authors, and this could be kept in mind. And when you use a pre or post balloon dilatation, you make sure that it's smaller than the smallest dimension of the annulus. Use a balloon to artery ratio of 1 for semi-compliant balloons and less than 1 for non-compliant balloons. Diagnosis, as you can see, you have to be on high alert, and anything that is patient develops hypotension and instability, you have to keep it in mind. You may have low arterial pressure, tachycardia, arrhythmia, as in one of these cases. He had ECG changes or circulatory collapse, as in the second case. Patient may report pain, as in both cases. Immediate angiography, if you're still in the cath lab, or echo, is the diagnostic modality of choice. Any evidence of bleeding the pericardium should arouse suspicion and should be managed accordingly. If the patient is stable, you continue imaging and assess the situation. Basically, reverse anticoagulation, put a pericardial drain, give blood products, and decide what to do after that. In unstable patients, like the second case, you have very little choice but to drain the patient, reverse, support, and maybe convert to an open stenotomy and put her on cardiopulmonary bypass through the femoral access or directly central. If the rupture is clearly identified, on angiogram, then you may try to deploy a valve inferior or more inferior or superior to it to seal the area.
Can you give 1 minute, please?
Yeah, I have one slide left. Thank you. Okay, so annular rupture is a catastrophic event that you don't want to see in the cath lab. It occurs in less than 2% of the cases, but carries a mortality of almost 65%. These patients, at least in most practices, are either inoperable or high risk, and they do not tolerate any open surgical intervention. The key to this is basically proper planning for the case and considering all the variables that could be preventable. Thank you very much.